Good afternoon, Dr. Masamo. Thank you very much for joining the NCD Academy of the American College of Cardiology. We are certainly very pleased to have you with us and very, very interested in hearing your story. As you know, the American College of Cardiology has been focused on achieving health equity, and we have been working primarily in the United States, of course, with most of our efforts. But we are a global, international organization, and we certainly know that the need for health equity and the need for reducing disparities, particularly as it relates to cardiovascular disease, is a worldwide need. And we understand that you have been doing some very, very important and impressive work in Kenya. And we would appreciate you sharing your life experience with us.
Thank you. Thank you so much, Dr. Douglas, for your warm welcome and introduction. Actually, I am not a doctor. I have to correct you there. Not yet a doctor, but I am a patient and a person living with sickle cell disease, and the founder and CEO of Africa Sickle Cell Organization that works primarily in sub-Saharan Africa to improve access to sickle cell care and to reduce health disparities for vulnerable populations. So thank you for having me, and I hope my lived experience will contribute to your wealth of knowledge for the Academy.
Very good. Well, thank you. I'm trying to push you along here with your doctorate, right? Very good. I understand that that you started a foundation. Is that right?
Yes. We started a patient-led, patient-serving organization that improves access to sickle cell care in sub-Saharan Africa. And as you know, sickle cell care is a major problem, not only in sub-Saharan Africa, but in the Americas as well, and in the Middle East. And for over 100 plus years, little progress has been made, especially within the continent, with regards to policy, financial prioritization, health system strengthening, and improving the health outcomes of people like myself, and especially those living in vulnerable communities. So we saw a gap there, and we are trying to resolve that gap through advocacy of health policy, action and programming that improves access, affordability, and availability of healthcare, sickle cell care, as well as patient-centered care, where we empower people living with sickle cell to identify, understand, and solve problems around sickle cell, personally in their lives, as well as in the communities that they live in.
Very good. Now, how many people in sub-Saharan Africa are actually suffering with sickle cell disease?
So it is estimated that 300,000 people are born annually with sickle cell in sub-Saharan Africa. However, due to the unavailability of data, this number is a large underestimate of the exact burden in the specific countries. Approximately, they say that 1,000 children are born each day with sickle cell in sub-Saharan Africa, but 50% of them do not make it to their 5th birthday. So that is a major problem. When we see our sister countries in the US and in the UK and in the other American continents, majority of people living with sickle cell live throughout their adult life and beyond adulthood. But in sub-Saharan Africa, majority, up to 90%, they say, do not reach their 5th birthday. So that's a problem. I am one of the anomalies.
I understand.
Yeah.
Now, what would how would you define the barriers that are most significant to people living with sickle cell disease in your part of the world?
Okay, so with regards to health equity and the barriers causing these disparities between the global south and global north, we have to understand that in the past we used a lens of equality where we treat everyone the same, rich or poor, man and woman, young and old, able and differently abled. But now we're moving to health equity that contextualizes patient needs to achieve successful health outcomes, especially for the vulnerable poor. So for us, we have to understand why these health inequities are there in the first place. And for those who may not be aware what health inequities are, there are unfair and avoidable health disparities between and across patients from different settings, contexts, and backgrounds that lead to preventable illness and death. These different settings and contexts include age, geography, sex, specific disease, economic and cultural backgrounds, and race. But what we see for sickle cell is that we cannot address these inequities by looking at the biological disease manifestation in isolation. So we have to look at the disease as the patient in a wholesome way, understanding the circumstances in which the patients live and work and grow and age and seek care that affects their health outcomes, which are now contextualized within the distribution of power and money and resources at national and local and global levels. And they are largely influenced by global, national, and local policies. In other words, these are the social determinants of health. For people living with sickle cell, if your level of education is low, then you do not know if you need to seek care. You are affected by stigma and discrimination within your context because sickle cell in sub-Saharan Africa has a connotation of witchcraft and demonic entities and ancestral curses that prevent positive health-seeking behaviors. Poverty is a very, very big thing where we see sickle cell affects highly poor communities, and communities like this do not have the basic needs, and therefore they will not have the ways to afford to even travel to seek care or go to seek care. And most of the places where we access care for sickle cell is centralized in urban areas, while the majority of populations in rural areas do not have access to care. And we spend large out-of-pocket financial expenses to travel, to go and pay for this care, and due to the early onset of sickle cell and the long-term effects of sickle cell, it is debilitating in terms of the amount of money you spend on a daily basis, and the impact in the household and how much it reduces financial income in the household. That affects access to food, affects access to employment, because once you are unwell, you cannot go to school, and therefore you are in that vicious cycle of poverty because you cannot access employment. And it's just an ecosystem of problems that we are trying to unpack aggressively here. So those are some of the things that affect. And we know in the US, there's interventions. There are interventions that have been proven to work, but still they're not accessible here in sub-Saharan Africa. Wherever they're accessible, we are still paying for them. And how can we be able to reduce that cost to the patient, that it can be affordable or even almost free for them to access this care?
Let me ask you, are there governmental programs that have been developed to address this issue? Are there structural programs and policies that you think are helpful in sub-Saharan Africa?
There are no policies for sickle cell in the entire continent in terms of national policies to prevent and control sickle cell. So that is something that we lack. However, based on what I've spoken about, just not looking at the condition itself, but looking at what is causing ill health and these factors worsening their conditions or actively preventing them from achieving good health and well-being. We look at there are specific innovations on healthcare delivery that have been seen to work in sub-Saharan Africa. And one of these innovation is a Pen Plus integrated care delivery approach. So this is an approach that alleviates the burden of avoidable death and suffering among the world's poorest children and sickle cell. And we have seen that majority of those people who are dying before the age of 40 are affected by severe NCDs like type 1 diabetes, sickle cell disease, rheumatic heart disease, and congenital heart disease. So this integrated care of delivery is addressing these severe NCDs together. That is something that has been proven to work in our context. Okay.
Very good.
Yeah.
I wish you would address one other thing that you mentioned that I think that we have not addressed as well in the United States, and that is, the false beliefs about the disease. You mentioned that people thought of this as being possessed by demons and those types of things. And there are a lot of, when we look at disparities in healthcare and distrust in the health system, it is very difficult to overcome, the belief system that many of our patients have. How have you all tried to address that in sub-Saharan Africa?
Okay, so for sub-Saharan Africa, these beliefs are grounded in culture and community, and it's something we are really it's difficult to tackle, but we have addressed it in specific ways. Like patient support groups and the social support, providing social support to poor sickle cell patients and coupling this support with information and education. So what we do is go into communities that are high burden in sickle cell and have rapid community outreaches to be able to educate patients and their families and the community that sickle cell is not witchcraft. Sickle cell is not a curse from your ancestors. And one of the interesting ways we do this is we do it with patients' lived experiences and patient stories. Because when a doctor talks to a patient or a family member or a community, there's a level of distrust that still exists there. But if it's someone living with a condition saying that I have lived like this, this is my symptoms, you can see the way I look like, and this is what I go through, but this is not witchcraft. I go to the healthcare center, I get the specific medications that I need, and I'm living and thriving well. So a patient is more inclined to listen to another patient than anyone else. So these are one of the strategies we use: authentic engagement and involvement of patients for patients and for communities. Yeah.
Very good. What about the school system?
Okay, so yes, it's good you brought that up, because the school system, this is even from my personal experience. I usually tell other patients that I have not faced the highest level of discrimination and stigma I faced in school. Because one, I did not know I had sickle cell. So my parents did not take the time to inform me that I had this condition that made my eyes jaundice, that made me visit the hospital every 2 weeks, have frequent blood transfusions and hospitalizations. So I thought this was normal because in our family, 3 of us have sickle cell. So it was like it's the norm for every child. But when someone pointed out in class and in school that I was different, the way I looked, my body, the distension of my tummy, my skinny stature, then it clicked. I was like, yes, I am different, and this put me in a very vicious cycle of self-stigma. So what we do for schools, because we cannot be able to do any interventions for children under the age of 18 without consent of the educational system, that's the government and also the parent, we go to parents. So for parents with children, we identify the children with sickle cell in schools and approach the parents and inform them about unpacking sickle cell to the child, how they can manage it in school, and how they can be able to inform their peers in a healthy, non-stigmatizing way, and how they can thrive in school. So we have parents who are for parents with sickle cell in schools to be able to unpack there. After that, we address the school system, the teachers who are teaching these students with sickle cell. How are you able to manage the health of the child in your class? Because they need specific levels of attention, the hydration. If you see the child is in pain, if you see the child is feverish, how do you manage and provide first aid in this case? And how also do you create an enabling environment for other children not to stigmatize the person living with sickle cell in the class? So this is a different package that we offer for teachers as well, and it has worked because it's not stigmatizing. I think the problem is the stigma. When you tackle stigma early for the child, then they're able to live away, to move away from self-stigma and be able to accept themselves, and therefore be able to inform others and educate others around them.
Very good. You know, as
Yeah.
we look at reducing health disparities and
Yeah.
improving health equity, we're always trying to allow people to live their fullest lives
Absolutely.
and not have barriers that prevent them from achieving their
Absolutely.
best outcomes. And so, you know, so if you are a child that really have parents or a community that's not very well informed about your disease, then it's hard for them to help you
Yes.
to mitigate those barriers. And so you have really underscored the importance of education, particularly
Yeah.
both for the individual suffering with the disease as well as those who are in their immediate community. And one of the things, you know, that we have as one of our pillars of addressing health inequities is the need for advocacy. And I know that you have done a lot of work with your organization, your foundation, on advocacy.
Yeah.
How has that been received from a governmental standpoint as we look at structural policies and barriers that exist in the government? Could you tell us a little bit about what you've experienced there?
Yes. For advocacy, I think you guys, like the US, is miles away, is miles ahead of us, and the way you organize for Congress and getting the funding needed for sickle cell is a testament to what we can borrow from your context. So for us, one of the major things that has worked is leveraging patient stories and lived experiences. So for my experience, when I was starting this work, that was in 2014, I approached the government and the policymakers and talked from my own perspective about sickle cell. But it didn't, it wasn't enough for me to just talk about it. And because there was a lack of data, and this is a substantial lack of data for sickle cell in sub-Saharan Africa, then priority in terms of financial, human resource, and policy was not a priority for sickle cell. So what I did personally, and what has been working for us as the organization, I took an initiative to tell the stories of 10,003 people living with sickle cell and their photos. I went to these communities to learn how they live, their experiences, and document these experiences so that I can provide justification to policymakers for change. But I didn't reach my goal of 10,003 because the situation was very debilitating on the ground. There was no access to pain management. There was no access to healthcare providers, no access to hospitals. Majority of the patients that I saw knew they had sickle cell, but were not properly diagnosed for sickle cell. Many misdiagnoses, high rates of infection and disability. And I couldn't find any child who was above the age of 10 because majority didn't even reach, the age that, you did not survive. So I stopped and I went back and I provided the evidence to the healthcare policymakers. And this provided impetus for them to fundraise and resource mobilize to the WHO and the World Bank for the national sickle cell guidelines for management and control of sickle cell in Kenya. And that was the first step. So a lot of the work that we do, we leverage patients and patient voices and patient experiences because we are still collecting the data that is needed to ensure sustained prioritization. And we have had major improvements with regards to policy because we have the guidelines now and we have the newborn screening policy now where every child in Kenya will start to be diagnosed as early as childbirth to know their sickle cell status, which was earlier not there. And unfortunately or fortunately, in Africa or in places like Kenya, healthcare is devolved. So it's not the national government who holds the power to mandate or to create policy. We also have local county level governments that it's like the US, like the states, the different states. So we have to devolve our advocacy levels to that level and target the different high burden communities and counties in Kenya. So we are creating and mobilizing patient groups and patient voices and empowering them to actually inform health policymakers and inform health systems in the communities that they live in. So that has worked for us, and in different, out of 47 counties, we have 17 counties that are high burden in sickle cell in Kenya, and at least 4 of them have sickle cell programs, which is very little compared to other places like Tanzania. But we are getting there, and this is the work that we're doing with patients on the ground, mobilizing and organizing for policy.
Very good. I think that is going to be key to your success.
Yeah.
Having an engaged community that is both knowledgeable about the disease as well as understanding, the barriers that exist for appropriate care, and a commitment on the part of the community and the government to being sure that these patients are cared for in the right way at the right time by the right people. One of the things, that I've been curious about is, we always think about sickle cell as being for protective reasons. This was it evolved as a mechanism of protecting people. Um, do you think that should we be advocating for an advancement in the science and the understanding of this disease? I know that there is a lot of research that's being done around the world about sickle cell disease, but should we be pushing for more resources, financial resources, if you will, to be applied to this disease that appears to disproportionately affect people of color?
Mm. Absolutely, and I think, and we all know that sickle cell has suffered a century worth of under prioritization compared to other similar diseases affecting different races that are more advanced with regards to research, interventions, and also availability of various essential medicines to treat those diseases. Um, so for us, it's a fight because we have to also look at the history. As you said, Dr. Douglas, it is purported to have a protective component, which it does to mild forms of malaria, but debilitating if you contract a severe form of malaria. But looking at the history of the context that we work in, global health, we have to understand also we are living in times where colonial legacies are still perpetuating within our ecosystem. Understanding that medicine was created for particular populations and was transplanted from Africa, developed in the West, and brought back with lack of contextualization with regards to the ethnic background, the racial background of its people, then it seeks to do more harm if we are still following those routes. And but by understanding that we are coming from a colonial perspective, we know that we need to move away. And how can we move away when the people who control the power, resources, and goods and decisions for global health are not majorly affected by this disease? So for us is how can we be able to leverage in the various movements that are holding power to account, like the Black Lives Matter movement, like the what you're doing in the U.S. Because the U.S. has connoted sickle cell to be a racial disease, which is a racial disease, and it is ethnically defined as a disease or affecting the Black race. However, the continent that is affected majorly is not in those conversations of race. Or we are divorced from that, and how can we work together, the Americas and sub-Saharan Africa, where majority of the African population resides and are affected, to be able to have more power with regards to our voice in terms of advocating for policy and financial prioritization for sickle cell. Because truth be told, this space is led by research experts that are donors with their own interests, developing interventions that will profit them. But how about the communities that are suffering, and how can we give these communities power to be able to leverage the power that already exists? So I think we have to remove the control of sickle cell from the researchers, from the high level researchers, to now the community, and drive it from a community point and resource these communities to be able to have a say in the policies and in the governance and in the systems that serve them. that is the one thing that we are trying to do in sub-Saharan Africa, how we can give these people power, because there's like acute lack of agency for people like me. So how can we bring power to that level? So Dr. Douglas, I don't know if you have any idea how to bridge that disparity of power. So that's why the social justice movements are coming up across the world. So we need to bring social justice to all our healthcare interventions for us to achieve health equity, not only for sickle cell or cardiovascular diseases or NCDs, but for all vulnerable populations that have been long left behind for so long. Yeah.
Well, absolutely. And that's a great answer to a very difficult question that we all confronted with. And, and one of the things that I think that the ACC's NCD Academy will help us do, and that is to spread the global word. That I think that the first thing that we all have to do is to be sure that people are highly sensitized to the needs of our communities, irrespective of your ethnicity or gender or sexual orientation. That those are the things, that we really need to dismantle, to be sure that resources are allocated as need arises and not based on a particular agenda, if you will.
Yeah.
And so I think that the work that we're trying to do at the American College of Cardiology, and particularly with the NCD Academy, is to empower our community, the medical community, about these barriers and heighten their sensitivities to the need for achieving health equity and to hopefully bring about the social justice that you mentioned. That is our goal and part of our vision. That we have spent a lot of time trying to be sure that we are clear-sighted as we look at what are the most effective tools that we have to achieving health equity, and particularly how do we create societies where there is social justice as it relates to all diseases and other maladies that affect our communities. And so what you are talking about, in particular the sickle cell phenomenon, really I think helps us to hone in to a disease that has that stigma that you mentioned, and because it is a disease that particularly only affects people of color, and maybe it has not received the amount of attention, research, and other efforts that are really mandatory to allow people who live with this disease to achieve their full potential. And so, I think that this has been very insightful for us. And I think that hopefully we'll be able to raise the level of understanding and insight into how disproportionate amount of suffering that occurs, and give us ideas about how we can address these issues.
Absolutely.
One of the things, that I think that we have done a pretty good job in the United States is that we are good about making people aware. Folks speak out and making people aware of where the resource allocation needs to go.
Exactly.
And and we have we've done a pretty good job of that.
You have.
But one of the things that, and I want you to address this, if you will, and that is one of the ways that we try to improve access to care is with telehealth. And when we started, COVID-19 created an opportunity for us to really move telehealth forward, out of the need to move it forward. And one of the things that we learned as we went through the pandemic was that there were large swaths of our country that really had very poor access to broadband internet services. Is I want you to talk about telehealth as maybe an answer or a possible tool that could be used in areas, particularly urban and rural areas where there is poor access. You mentioned in your opening comments that one of the major barriers for people living with sickle cell disease is that they had to travel long distances to urban centers to receive care. Is telehealth a potential solution to that problem?
Yeah.
Yes or no?
Well, yes and no. So telehealth, and I think that was one of the benefits of COVID, if there were any, that it brought about the development of infrastructure and telecommunication technology to facilitate remote and virtual communication. And for health, especially in sub-Saharan Africa, because we are increasingly developing continent, we have a large penetration of mobile phone technology and mobile phone interventions with regards to healthcare. And there are specific ways that they use telehealth through providing AI-powered triage, especially during COVID. So instead of going to the hospital, an app called Babel in Rwanda provided AI-powered triage, where AI asks you the questions and filters you and directs you to the right medical specialist who will be able to address your need, as well as using live video and chat for those who have smartphones. And I think the biggest benefit is personalized health that is universally available, especially at a distance. that is the biggest benefit. So yes, it has its benefits for patients, especially for those who are able to use these devices from a distance and don't have to travel long distances or have to wait on long queues, or even inconvenience yourself and expose yourself from risky infectious diseases like COVID. So it is convenient, it is low cost, it is personalized, and there are no wait times. A lot of patients do not like waiting. But one of the biggest shortcomings, especially in sub-Saharan Africa, although we have a lot of mobile health technology, is that penetration is also a problem, especially to the very, very, very poor communities who are illiterate. They cannot be able to access these platforms, people who cannot read and write, and we have a large population that cannot read and write, as well as it cannot be used for emergency care. So chronic conditions that require highly specialized care and emergency care services, this is not very applicable at this time unless it is further developed in the future. And we also have problems with data protection and also that specialized chronic care management. So for me, I think with regards to providing education to patients, will work very beautifully, because most of these platforms can contextualize language, can contextualize images, and help the patients actually understand. And especially for sickle cell, if we are trying to reduce stigma and we're trying to reduce misinformation, I think this is one of the best ways to do it. And get the results that we require without a lot of financial investment. But also the opposite is true, that we can spread a lot of misinformation with these devices and lose a lot of patients in the process. So I think in my opinion, during COVID, let me just tell you about my experience. I work in a very, very rural place in Kenya, and all the conversations were happening virtually. Everything was on Zoom. And however, we had interrupted power outages. We have every 2 days of the week, there's no power. And I was the only one who had access to a laptop with the internet, and I was the one who was representing the voices of that community that I work in. So it still largely leaves a lot of people behind, especially those who do not have access. So it is a device that bridges the gap, but also perpetuates health disparity for those who cannot access, because their voices are not represented. They're not able to speak for themselves. And I love technology, but it really left a lot of people wanting during COVID, for a very long time, before actually we realized that there was a population that was being left behind because they could not access virtual platforms. So it's it's a double-edged sword. Yeah. But how do we include these communities?
Right. How do we democratize
Yeah. Exactly.
access to the
Yes.
platform? Yeah, and then
Yeah.
and we have struggled with this, Leah, in that it has the potential to widen the gap, if you will,
Yes.
for those who are left out and left behind. So it could be a very, very powerful tool for good, but it also can widen the disparities gap
Yes.
if we're not careful. And so, we really have to work on the policies
Exactly.
from a governmental,
Yeah.
societal standpoint, that you have to have access to this technology in order to live your best life, if you will.
Yeah.
And and it is becoming so integral to our lives that if you don't have access, then you're not going to fully achieve your best health outcome. And so I think that what you are describing, that you experienced in Kenya, I think illustrates that point very, very well. It could be a very powerful tool for good, but it also could leave a lot of people in need behind. And so we need to be pushing to be sure that everybody has access to all the things that they need in order to live a full and healthy life. So that, I think, I appreciate that, and I hopefully that point is well made and understood by those who will be listening to this broadcast. That we really have hidden barriers, that may not be quite apparent to everyone. The assumption is that everybody has a cell phone and everybody has access to reliable internet services, but that is not true worldwide. And oftentimes the people who need this service the most are the ones who have the poorest access.
Exactly.
So I really appreciate you sharing that part of your story with us. Now let me finally, and the last thing I want you to talk to us about, and one of the things I think that may expose you to some degree of vulnerability, but I want you to do this for us, and that is when you are a patient. When you're not just an objective observer of a particular disease, giving advice or giving care or providing service to someone who suffers with something. When you are the patient, it really gives you an insight, and I think probably a level of sensitivity and passion for advocacy that those of us who don't suffer with that particular disease just don't have.
Yeah.
And as our last topic here this morning, afternoon for you, I want you to, if you would, and I know that this is personal for you, but would you just share with us how living with this disease has informed your passion for advocacy, passion for education, passion for research and scientific investigation of this disease? How has living with the disease really kind of fueled your way?
Okay. Thank you, Dr. Douglas. All I have known is sickle cell. As I mentioned earlier, that I was born into a family where 3 out of 4 children have sickle cell. And unfortunately, we lost our elder sister who succumbed to malaria. But my other sister is actually in Maryland, and she is privileged to have the care from Johns Hopkins Hospital. But be that as it may, I also come from a community where 24% of the population have sickle cell. So the neighbor of my neighbor has sickle cell, and the neighbor of the neighbor next to her has sickle cell. So this disease has been with me. I've experienced the personal pains of the disease, the severe debilitating pains, and the loss of time in school, loss of time at work, and the stigma and discrimination. And I'm also seeing how my parents interacted with me as they cared for me, as well as the community around me. So I know sickle cell through and through, and I think all that experience over the entirety of my life has fueled my passion, and I feel like I'm in a position where I am better than a large percentage of the people that I serve, because I was privileged to grow in a family where we're moderately it was a good upbringing. I cannot complain, and were able to afford care. My parents had health insurance, and they were also eager to be informed of how to better care for us. So I come from a very privileged family, where so the communities that we serve, the families break because of this disease. And there's blaming of this is not my family, this curse is not from our side of the family type of conversation. And also now the patients cannot be able to access care affordably, early enough, and throughout the continuum of care of their entire lives. And for me, I felt a sense of responsibility to be able to provide care for these people, to provide solutions, because I identified that even though I came from a family where most of the things were catered for, I also experienced the pain and all the suffering that comes with sickle cell. So how much burden are they bearing without these comforts that I grew up with? So I felt a sense of responsibility to give back and to pay forward, because I have a very high likelihood to give back to children with sickle cell. So how can I be able to support others, make it a better environment for others, and also in retrospect and in prospect, make it a better environment for the children that I will bear into this world. So for me, my passion is not for small interventions that will maybe make a difference. I want people to thrive, people with sickle cell to thrive because they have sickle cell and despite having sickle cell. So if you have sickle cell, you are in a better position of thriving. Where in the sense that where we are at now is that because you have sickle cell, you will not be able to thrive. You will suffer your entire life. So for me, I'm looking at the opposite spectrum. How can you thrive even with the disease? Because we know that the cure is far from being practical and accessible for communities where I work in. So how do we make lives better for those people who have the disease? And for me, it's not a career, it's a vocation. And I think even if I do not achieve this dream and this goal, the daily attempt and the daily trying and the daily pursuit is worth the while. And I know someone else will pick it up after I'm gone. So that's where everything comes from.
Very good.
Yeah.
Very well said. I really appreciate that, and I think that your story and the work that you're doing is very, very helpful as we try to deal with the need for dismantling structural and policy-driven barriers that prevent people from living their full lives. And at the American College of Cardiology, as we do these videos with the NCD Academy, we're hoping that we will give people not only an educational experience, but also by exposing them to people who have lived experiences that will help to raise their level of sensitivity and even inspire them to, as I like to say, get in the boat and help us to sail towards an island of health equity and social justice. And so your story and the discussion that we've had this morning, I hope will help us get people in the boat, because we all need to be rowing this boat together. This is everyone's responsibility. This is a worldwide, global responsibility. And we're hopeful that the work that the American College of Cardiology, and particularly the NCD Academy, is doing will help us to achieve that goal that you so eloquently spoke about. And so thank you very much for spending your afternoon with us. It has been very insightful, and I pray that we will be wonderful partners for you as you go about the sacred work of helping people who suffer with sickle cell disease.
Thank you so much, Dr. Douglas, for having me and having this very much needed conversation about sickle cell. I know you were speaking about cardiovascular health, but I am looking forward to the many partnerships that we will have to educate people about sickle cell and to also improve policy and resource prioritization for sickle cell between Americas and sub-Saharan Africa to actually solve this problem and also improve the health and well-being of people living with sickle cell. So thank you again, and looking forward to further conversations on this.
Very good. We look forward to our collaboration, and we certainly want you to help to inspire us and to guide us, and we want to use all of your resources and your knowledge to help us to achieve health equity.